So welcome everyone. My name is Diane Padilla. I am your presenter for the next little while, and I am going to be going back and forth to my slides, and there are different things that I'm just kind of want to get out of the way in the beginning, logistically, and then we will go into the content. Meanwhile, I didn't send you this ahead of time, but hopefully I'm going to put a case scenario inside the chat. And so while I go through the logistical aspects of this webinar, what I'm going to ask you to do is if you can kind of click on it and just save it onto your desktop and have it available, it may make it easier for you to read. I'm going to have it on my slides as well, but that's a good way to kind of back it up. So again, good morning, everyone. Welcome to Trauma Strategies for Peer Support Using Self-Care. My name is Diane Padilla, and this training actually is brought to you by the Northeast Caribbean Addiction Technology Transfer Center. Here, I just want to talk about how we're funded by SAMHSA. The SAMHSA doesn't check every single piece of paper that we put out. But thank goodness we do rely on our own reputation that we have of bringing you the most research-informed, expert-informed, best practices, and whatever's latest in the field. We tend to give you what's been out there, and I cite sources from the last 3 years. We tend to use all the current information available and not things like 10 or 15 years ago. What's not relevant, it's not important for you to know. It's whatever is going to help you in your job today. And so the purposes of technology transfer centers, this being one of many that SAMHSA supports, is just to provide you workforce support. And so no matter what your position is, what capacity you serve, in what setting, we're able to bring you the latest information, build your knowledge, build your skill sets, all that so you can keep your credentials and keep doing all that hard work with our communities. And language matters. Words have power, people first. And this webinar is designed specifically for the peer professional. And persons who have CASAC or CPP, CPS credentials can also benefit from this. But in terms of the work that the peer professional does, we as peer professional, we know that how you use words is really important. And so I'm going to stop the share here first. And I'm going to ask someone if you'd like to speak to it or put in the chat box why words matter and why. And if you've been to any of my trainings before, you'll know that I make a big deal out of it. And there's a reason for that. It's not an opinion, it's something that comes not just from the research, from all our funding sources. So why do words matter? What's the whole idea about using people first language? And please raise your hands electronically so I can see you. Oh, great. Good morning, Daryl.
Good morning. Because words can either alienate a person from you or bring people closer to you.
That's very good. Thank you so much. That's great how you put it. Diana? Diana's in the house.
Yeah, I think it sets a sense of safety, that if you're using terminology that is person first, I feel a little bit safer with you.
Yeah, thank you. So it is all about the impact on the other individual. And so for many years in the field, whether some folks were how we work with people in treatment or how we work with people or how professionals work in the different disciplines, mental health, addiction, recovery and prevention supports, for a long time we used different words that was appropriate for the time. But today what we're trying to do is make sure that our language reflects support and inspires hope, and folks feel like they have an ally with us and not feel like they're judged. And quite a few of you folk put down here about the stigma. And stigma is one of the biggest reasons why folks don't even access care. And so it can be reflected in language. Now, back in the day when we were taught certain things, when we were trained, when we went to school, terms like substance abuse, substance dependence, that was appropriate then. That's what we knew, that's what we did. That's not what we know anymore. We know better now. We have evolved. We have spoken to the community members themselves. We've spoken to the folks who don't access our care or the ones who have been in our care and kind of fell out of care because sometimes some of the language that we use makes them feel like they're being judged. They don't feel motivated, and they go even deeper into their isolation and such. And so stigma has been a really a huge barrier for communities in general, for individuals. And so we try to use recovery-oriented supportive language as opposed to stigmatic references. So even though we may have been in the habit for certain terms in the past, we encourage folks to start to evolve your own terminology. Just like you evolve your own professionalism and you add more skill sets to your tool base, your toolbox, that's the same thing that we're asking you here. So going forward, that's how we will do it. I see. So I see words tell others how we view them. Yes. And it puts a person first, not identity, not identify them by their disability, whether it's physical or behavioral. And so we can work on this for, I have other topics where I go into this in depth. Allow let the person tell you how they identify. But it's for us as professionals, since we have to know certain terminology. We translate that terminology in words and in language that client understands, that patient understands, but they don't know our clinical terms. They don't know our peer advocate types of terms that we use for our work. They know how we discuss things with them. Here's the biggest thing. It's something we kind of forget about sometimes is that even though you're a big heart of hearts, you're in this field and you want to work and support folks, the words you use have an impact and your motives don't. Despite how much you want to help someone, it's the words you use that is going to impact them because they're going to interpret it a certain way. And interpretation is something we're going to discuss today. So thanks everybody for that. This has been a good way to start. So here I'm going to do something. So you have, I really like to kind of just hit the ground running today. So if you don't mind, and let's just kind of get our energy up. I need a volunteer to read. Everyone else, you have your hand. I put a handout in the chat box. Next time I'll send it ahead of time. Tree's the one that I should have given it to Tree to send to you. So you can read along with us. Sylvia, you want to read for us? I'll put it up on the screen.
Yes, ma'am, no problem.
Good morning. Glad you're here.
Morning.
All right, let's go with this.
Okay, you ready? Case, Sandhana. Sandhana is a 22-year-old woman mandated to outpatient mental health and substance use treatment as an alternative to incarceration. She was arrested and charged with assault after arguing and fighting with another woman on the street. At intake, Sandhana reported a 7-year history of alcohol use and one depressive episode at age 18. She was surprised that she got into a fight, but admitted that she was drinking at the time of the incident. She also reported severe physical abuse at the hands of her mother's boyfriend between ages 4 and 15. A particular note to the intake worker was Sandhana's matter-of-fact way of presenting the abuse history. During the interview, she clearly indicated that she did not want to attend group therapy and hear other people talk about their feelings, saying, "I learned," I can't see the rest, saying, your thingamajig is in the way. Wait a minute. "I learned long ago not to wear emotions on my sleeve." Sandhana reported dropping out of 10th grade, saying she never liked school. She didn't expect much from life. In Sandhana's first weeks in treatment, she reported feeling disconnected from other group members and questioned the purpose of the group. When asked about her own history, she denied that she had any difficulties and did not understand why she was mandated to treatment. She further denied having feelings about her abuse and did not believe that it affected her life now. Group members often commented that she did not show much empathy, even when group discussions were emotionally charged.
Thank you, Sylvia.
You're
And now the question for everybody, and in terms of, you have the handout because I have this on 2 slides. It's pretty long. It's longer than what I usually put up. But in terms of what you've heard and what Sylvia read out to us in the few details that you know, and you're meeting this person and you're learning these things about them, what would you say are some concerns that as a peer advocate or as a professional, you would have to, you would consider having to support her on? So what do you perceive to be the concerns to support as a peer support, as a peer advocate? What are some of the things? Let's start jotting either in the chat or raising your hand. Daryl?
I would probably, as a SERPA, I would probably support her on her choice of treatment, as far as opposed to group therapy, as opposed to one-on-one therapy.
Okay, her choice of treatment. That's it. That really supporting her in her autonomy. Thank you.
A particular pathway to recovery. I would support her on that.
That's right. That's right. She we do know that with as a peer, what you want to do is understand how they identify recovery and which direction they want to go. Thank you. All right, so I see some folks are putting some stuff in the chat. Okay, she didn't feel she needed help. This is true. She may not have felt that way. Let's see, seems like she may be depressed. That's right. She may be disconnected from her feelings. Different resources so that she could choose where she could possibly go in the future. She does not see a problem. So let me just stop there for a second. So she doesn't see a problem. So how do you support her? Actually, this one's a no-brainer. How would you support her?
I don't know if the word support applies to my response. I would ask her questions to hopefully make her aware of the negative consequences that her drinking had. So if she's drinking was not a problem, I would just continue to ask her questions. So hopefully she could see, oh, especially in this instance, when I drank, when I got to the fight, I was under the influence. And any other negative consequences that she may have. Well, you know, if there are negative consequences involving her family or employment or school, I would use questions to see it so she could see that, oh, maybe alcohol has been a problem for her. I don't know if that's not, but that's for me to try to help her move from the 5 stages of recovery to move step 1 to step 2.
Okay, thank you. Tanya, good morning.
Good morning. I was just thinking about meeting her where she's at instead of meeting her with resistance. And sort of saying to her, asking her the questions. Well, if you don't have a problem, why do you think you're here? What can you get out of this since you're court ordered? What are some things that you think might be good to talk about, and meet her where she's at instead of trying to demand that she has a problem with her?
Right. Thank you, Tanya. Meeting the person where they're at. You know, it's interesting because you can meet somebody where they're at and you can see some things, but if they don't see it, you still have to work from that. You don't have the opportunity, though. The other things that you do see about the person, you can utilize that. That can inform how you support. Thank you so much for that. Jairus, did I pronounce your name right? Good morning. I'm not sure.
Good morning. Yes. You can call me Jairus, so you can call me Ox. I was going to piggyback on what the young lady was just saying. But also there seems to be a disconnect about the idea of help since it's mandated. So getting her understanding, her complete understanding of what she is there for to help address the issue, to help her, because if she doesn't see it as help, she's going to be resistant the entire time.
Okay. All right. Thank you, Jairus. Malaika, good morning.
Good morning. Like Tanya said, she has to direct what the help is that she wants. So it's not my job to direct her. It's my job to listen to what she feels she needs and then help her accomplish whatever that is. So the conversation would be more so, well, you're mandated to this treatment facility. What can we get out of it? What do you hope to get out of it? And whatever she thinks it is, then we move towards that, because the more she's engaged in the treatment, hopefully the treatment will work. And that will help her come to terms with the alcohol and maybe the anger issues or the trauma. But as a peer, my job is kind of just to support her, maybe help her make sure she makes the groups, remind her that she has group on Tuesday or whatever day it is, so that she stays connected, but not so much so that I'm telling her what she has to do. She's telling me what we're doing. And as long as it's in a positive direction, we kind of follow that until she kind of comes to some kind of clarity on her own about what she needs.
Great. That is excellent. Excellent. Thank you, Malaika. Thank you, everyone. Really wonderful comments. You have to work with her where she's at according to, and to understand how the the substance use, how that played a part, how it impacts her life. What you also have the opportunity to do is to understand how, like Jairus was talking about the disconnect. You can see that some of the behavior seems contradictory to what she's saying. You still have to work what she's saying, but you also can understand some of the other dynamics, especially from her history, why she may be responding the way she does. And you don't have to be a clinical, a clinician for all that. It's just a matter of like, okay, so the behavior doesn't match the words, but you know what? We're going to help understand. That's going to help us understand why we need to be person forward, why we need to be trauma informed, why we need to be kind of understandable when there's a possible reaction that may not necessarily kind of fit the situation, and we still have to support. So that can help us to help her. And so, yeah, mandated treatment assists her in reaching her personal goals. Agree with everyone. Very good. A couple of things, a few things about this case. This one I borrowed from the actual manual. And so the thing about Sedana's case is a lot of folks, when it comes to traumatic experiences, especially when folks go into treatment, not a lot of people understand that they've had traumatic experiences, or it can take a while before they can even recognize that trauma had played a part in their life. For some folks, it could be normalized, and then for some other folks, the way they respond on a very individual basis. There's no templated approach. So sometimes also folks have a difficult time regulating their own emotions, and we're going to go into how that works, why that works the way it does. And many times people are actually trying to use substances or drug use or the behavior that comes with it as a way of trying to mitigate, those traumatic situations, those memories, and the impact of that. We're going to unpack that a little bit to give us understanding, some fair understanding of how we can best support someone with trauma issues. Not everybody understands that they've had trauma. That's why sometimes when I speak to some folks who work in the field, it's like, if you're going to ask about it, be mindful of how you ask. You ask, if I'm one of your new clients and I come in and one of the first questions you ask me when I've only been abstinent for 2 weeks and my mind can still foggy, and you're asking me, have I had any trauma issues? That's very direct. I don't know what you mean. You know what? I'm going to yes you to that. So, and that's a potential way that I might respond to you. You may not capture all of my information. So there's certain preventive, approachable ways of being that would help that person be more forthcoming with you. And so we'll talk about a little bit about that. I just also want to put something. Sometimes what we see, the other person doesn't see it. An individual cannot work on something they don't see. And so I know we talk about like denial and all that. I'm going to suggest that we consider that from a different perspective. Because if we have a client that has an issue that we tend to see, or other providers who are working with this person tend to see, that person doesn't see it, how are they going to work on it if they can't acknowledge it for themselves? And what happens is that the mind may not be at a point to be able to understand or admit or recognize it. And we're going to look at how there's a real brief look on how and why the brain works the way it does with trauma victims. So very good way to start. And so let's define trauma. You folks want to you folks want to define trauma? Can anybody do that? Okay, I'll do it for you. So trauma refers to this. I remember going to some trainings and used to say refers to an event. Let me just put it in this way to make it easier for us to understand. And a situation can occur, an experience a person can have, the way that person interprets that experience determines whether it's traumatic or not, whether it's fearful, whether it's dangerous or not. And so it's a person's experience of events or circumstances that helps determine whether a situation is traumatic. It's trauma also refers to sometimes how long the impact can be around for some folks. For some folks it's short, for some folks it's longer. We're going to look at some of that. Some of the reactions that we are familiar with is when someone has traumatic experience, and we've heard a lot of times over time, we've heard about the fight and flight, where somebody is affected, and in the moment they're like either ready to fight or they run away to get they run away for safety. There's also the freeze component where somebody's capacity is just at the moment they can't move. And so once you become aware that different experiences impact people very differently, that we start to really understand that any kind of these reactions is just a normal reaction. It just depends on the person. So there is no right or wrong way to feel. There is no, there's nothing like that. It's really about when we support clients, and I think it was mentioned earlier. I think it was Tanya that mentioned earlier. It's about when we interact with folks, understanding that we want to be preventive. We want to be transparent. We want to be clear with our clients. We don't want to re-trigger reactions. So if we want to be able to let folks know, this is how we're going to work. This is what I'm here to do, and make sure that there's no surprises later on your part. It builds your credibility, but it also helps them feel safe because they know what they can expect from you. So instead of, and I think someone mentioned this too, it's like, we don't want to ask folks about what's your problem. We want to ask, so can you tell me what happened to you? Earlier, somebody was talking about how to, again, I think it was Tanya when was talking about asking the individuals, actually all of you were talking about asking the individual what they want to do, what their needs are, and what direction to go to. Asking open-ended questions is really interesting, way to help someone to tell you what direction to go in, to get them involved, to help them understand that they are participating in their own process. The idea here is that no matter what the reaction is, there's no right or wrong way. So it's very much idiosyncratic. After a person's experiences a traumatic event, anything they feel, any way they respond, whether it's immediate or whether it's later, that's a trauma response. It's very individualized. And so, and here's the other thing, it's like, if not everyone who experiences a trauma event will develop trauma. Could you imagine if after us getting through the last 3 years, last 3.5 years, we're into year 4 since the pandemic. No, since 2020, 2021, 2022, we're going, 2023, we're going to year 4. And so could you imagine if every event that is supposedly traumatic, we'd all be traumatized all the time, and that's not the case. Not everybody experiences the same situations the same way. Daryl?
Yes, I found that, I thought I had a pretty good understanding of trauma, at least for a layman, but it was very interesting, especially the last words that you said, that it depends on the person's own interpretation of the experience, whether it's traumatic or not. I started thinking like, okay, let's say 2 kids get on a roller coaster. One kid may get off the roller coaster like, yo, that was the greatest ride of my life. Can I get on again? And another kid might be traumatized by it. Same ride. And I thought that was kind of very interesting.
I think that's exactly right. And you know what, when we think, I remember one time we used to ask folks, what would be a traumatic event? And folks would come out with some of the most, say, the most extreme things like disasters or car crashes, things like that. And then we didn't always think about at first, this is years ago, but we didn't always think about it at first that for an individual, their parents divorcing can be traumatizing. Watching a friend, relapse can be traumatizing. Many experiences that we don't necessarily think has the extreme details, like we're in one of these movies where you see all the graphics like really being intense and stuff. It depends on the person, and it depends how they interpret. And your body plays a part in it too, because many are very often what happens in a situation will occur, and your body reacts to it, and then it kind of sends messages back and forth to your mind. Our central nervous system has 2 parts to it. There's one of it, the parasympathetic system, is the one that kind of keeps us calm in the moment, helps us get the ability to kind of work through things in a nice, calm way. But then you have the sympathetic nervous system that is the one that kind of initiates the fight and flight and freeze thing. It's the one that helps us survive. that in the moment, it'll do what it needs to do to help us survive. So when that gets activated, all our organs, all our body systems, or everything is like high stress. It's not on that high active mode. And so that activated level can put people in a very stressful situation, a very stressful condition, and that can impact, when it's done over time, consistently, that can have an overall impact on the individual. And so what we want to do is kind of help the person to kind of maybe learn some breathing techniques. I used to do this with some of my past clients, where I used to show them how to just breathe in through the nose and out through the mouth, just something simple, nothing super clinical or super technical. It's just in through the nose and out through the mouth. You do that deeply and let it out very slowly, kind of like a breath, like a whisper. Do that by the third time. You'll find that your heart that was racing will calm down. You'll find that the agitation overall in your body will calm down. And the more you're able to do that physically, the more likely you can articulate what you're going through. And so many actual therapists actually do this with a huge, with a good 80% of their patients. So that way they can start to process and help them kind of work through those situations. And so what we notice is that the body will react very often first, and that impacts the ability to whether the person is going to be in the moment, is going to kind of run away, it's going to just be reactive, that all plays a part. Let me look at see what you folks are putting down here. Yeah, trauma creates a feeling of extreme vulnerability. We're going to talk about that. Perceived by the value the client holds, relate to playing Mario Brothers. Experience level has this traumatic experience. Mario Brothers. I'm sorry, I thought about the commercial I saw yesterday about the movie coming out. They're actually making a movie about that. So, okay. So, it's interesting though, but it's very individualized. And there was a time where we used to look at that and say, well, why are they acting like that? Like that wasn't called for, and it's like, no, now we understand, oh, maybe there's something else going on. We don't take people for granted. We don't look at what's going on the surface. We start to think about what is causing something. And that helps inform how we support. So some of the responses can be, if for some folks, what we notice is, and this is what the data shows, is physically, people who have been under a lot of trauma or have chronic situations that have continuous trauma in their life, they may be hypervigilant, or they may be in the other extreme, they may be very low energy, they may have somatic complaints. It's interesting, you have people who actually will end up in the emergency rooms with stomach cramps, and the medical community may not recognize that it's not necessarily a physical issue, but a somatic issue where someone may have just gone through an experience that had caused a distress in the body, and it shows up like with stomach cramps and things like that. They can have an imbalance of, an imbalance in their motor skills and their coordination, emotional responses as well, anxiety. Numbness we see as pretty common with a lot of folks. In Sedona, we saw a lot of the anger. That could very much be normalized in her world, because that may be the way she deals with situations. That the mind is amazingly resilient, has a way of trying to adjust to different situations. And that could be a response or an opportunity of adjustment of how she reacts, how she deals with certain situations. But it can also be a lot of fear, avoidance. We know about that. And we'll talk about that a little more. So the behavioral part, aspects of it, the substance use or the eating disorders, compulsive behavior, whether it's eating, whether it's gambling, whether it's over shopping, whether it's overusing, different things like that. Isolation sometimes from other people can be a trauma related response. And the thing what happens with the mind is like really informs what happens with the rest of the body. So some people cannot concentrate, some people have a hard time going to sleep, some people cannot focus too long, or some people, what happens is they are distracted. They're not in the moment. They may be physically present, but they may be caught up in their memories. And so flashbacks may be part of it and more. So risk factors for trauma has to do with a lot of different things, a lot of life situations, really. So the intensity and the nature of the event can have something to do with why someone may have a traumatic response to something. How many stressors, and like if it's chronic. Now think about maybe someone who has, so Sadhana was being abused by mom's boyfriend since she was from the age of 4 to 15, 9 years of having to deal with abuse. So that chronicness, that chronicity of that situation, it's certainly understandable why she's having a lot of these reactions. So the length of time you're exposed, other situations, environmental factors like living under the poverty level, dealing with discrimination on a regular basis, maybe having mental health issues, not having healthy support systems. So you have housing instability. You also have poor coping skills, which a lot of times kind of underscores the exacerbation of mental health or substance use. Negativity and pessimism, learning problems, all of these risk factors. I look at that as vulnerabilities also, because risk factors increases the likelihood that someone may be impacted likely more than another person. So that's vulnerability. And so one of the things that we have learned about, and I think a lot of you don't understand about this, is the adverse childhood experience. So how many folks have heard of the ACE studies? So interesting. Thank you. You had your hands up. I appreciate that. It's kind of hard to be in this field and not understand this. Folks who go into treatment, and a good amount of them, from I think 85 to 90%, have had some kind of ACE, some kind of traumatic issues when they were children. When a person is developing from infancy to toddler to young adolescent, later adolescent, and so on and so forth. Many times, since the brain hasn't fully developed until they're 25 or 30 years of age, many times different situations that can be experienced as trauma. When an individual doesn't have coping skill, when an individual is trusting their guardians, the adults around them, and they're actually being impacted, they're being abused, or they're witnessing a lot of traumatic situations in their world. What happens with the mind is very resilient. The mind will adjust to it, but it doesn't mean that anything got resolved. So it kind of builds on each other. And so in that building on each other, those vulnerabilities, those risk factors increase. And that's what we see in the ACE studies. Jairus, please go ahead.
Yeah, really made me think about, or the example I had thought in my head was how kids who go to kindergarten, they don't know if their actions are right or wrong until they're put in a setting with other children. And now maybe the teacher says you can't throw something, you can't hit. And a lot of times it may be that learned response from watching the adults or the other people within their sphere. And then once you go out into the world, you see how the world responds in a different way. So the disconnect, how I've learned to do it, to what is now acceptable outside of my own social sphere, creates some of that disconnect as well.
Yes, thank you for mentioning that. So we've all been conditioned over time to how to survive our world, how to navigate through our world. So all that learned experience like Jairus was talking about, that's all part of how we also adjust to the different situations, how we survive our world. And children, as they grow up, what doesn't happen is it doesn't go away. Even folks who get caught up with addiction, a lot of times what happens is that unresolved issues that maybe people thought they were dealing with by not having to deal with it, or thought they dealt with it and didn't understand it had more of an extreme impact in their life than they thought. What happens, that tends to underscore substance use, that tends to underscore mental health issues, that tends to underscore a lot of the behavioral problems that a lot of folks may have. Although we don't always know that, because the average person out in the field, the average person out in the community doesn't necessarily know these things. And we don't get taught that as we're being raised. And parents don't know that because the infants don't come with a how to raise book. type of thing. And so we, a lot of us kind of learn it, you know, in hindsight. We go to school and then we can kind of link up the experiences, understand, oh, that's why I did that. Oh, that's why I saw her do that, or and so on. And so with the ACE studies, it's interesting because they were able to do that, looking past and link it up to the present. And so in the ACE studies, they found 17,000 people. One of the biggest samples, and samples, I'm talking about the different people, 17,000 people, so I'm calling them samples right now. So there were 17,000 individuals that were in this study, one of the largest. Usually, a lot of studies just have a few hundred, but don't necessarily, you know, and reflect patterns, but don't necessarily have this amount of people. What they did, they followed folks' trajectory since childhood into adulthood. And what they found is that the more experiences they had, traumatic experiences, adverse experience they had as a child, the more likely they were later on in adulthood be in position to have certain conditions and problems. And so for male participants, 30% of physical had shown that they had physical abuse, 16 or sexually abused, almost 8% emotionally abused. And then you see the female participant, 13% were emotionally abused, 27 physical, 25% sexual abuse. And what it speaks to is that while you're a child and you're supposed to be developing, it disrupts healthy development. And so the neurological circuits can kind of impact it. And so it also means that there can be certain amounts of impairment, emotional, social, cognitive. We saw numbing with Sedana. Well, guess what? That's kind of a way for the mind and the person who's growing up to kind of be able to survive their environment. But it doesn't necessarily mean that they can process information well. Emotionally, they may not be able to regulate their emotions. A lot of these folks end up having health risks later on and mortality issues or early death. So, and then this is a little graphic. I'm going to show it to you anyway, because it kind of speaks to what some of the data has shown. People have experienced trauma, especially those in childhood, right? They're 3 times more likely to be absent from work, more likely to have to use antidepressant medication, 4 times more likely to inject drugs, 4 times more likely to develop sexually transmitted diseases. And that could be a way of kind of getting out of yourself to not deal with the traumatic issues that the behavior can, a lot of different behaviors not used. Using substances is a behavior to help somebody kind of get out of themselves. It's the same thing with like, with having too many partners, you know, and unsafely, that can be part of it. There's no black and white, there's no absolute, but there's a lot of potentials, you know, a lot of possibilities of what we see. There are folks for 4 more times to become an alcoholic, 15 times more likely to commit suicide. Almost 3% 3 times more likely to use tobacco, have serious job problems, experience depression and such. So what you see is that the more that someone has had it, particularly when they were a child, it doesn't have to be just infancy, could have been 7, 8 years old, or as an adolescent. The brain is still developing, the person is trusting their environment, and these things happen and there's no support and there's no way, or they have not been able to learn how to resolve. Well, guess what? It gets stuffed away and it increases their vulnerability for these other situations. And so what we see sometimes with some folks is that we do see certain types of disorders. Now, there are certain reasons, there are certain conditions that would have someone respond a certain way. Sedana probably have PTSD and maybe a couple of other things. But we do know that when someone experiences a situation, acute stress disorder can be part of it. One of the most common things is if you're not a robot, you're human, you're going to feel a situation. It's very rare when someone is in a car crash and I'm not talking about, excuse me, a fender bender. I'm talking about a crash that is very impactful, and it's very rare that somebody goes through that and not feel something immediately, a fear or a numbiness, a shock. A lot of folks are in shock for a long time. With acute stress disorder, what happens is that someone will react, the reactions may be present within the first month, but then after a while, they kind of go away. You know, like that's more common and that person kind of processes it out, you know, it doesn't last. And so they may have maybe for about a month or so, they're kind of avoiding things that remind them of cars, or don't want to get in a car, or anything that kind of has to do with a car crash, or maybe they are being disassociative, their moods, they're not as engaging, and that can happen with the first 30 days and then it goes away. That's acute stress disorder. If they meet a certain criteria, they can get diagnosed with that. What happens with a lot of folks is the PTSD. We know the term, but we don't necessarily understand or are aware that many times for somebody to have PTSD, the reactions actually show up around like 3 months afterwards. So while some folks, like average folks who can just go through a traumatic situation and just after about a month or so, they kind of feel themselves, they're back to feeling like themselves. Someone who has PTSD, who may have interpreted a situation or for a lot of different reasons, may have these feelings and these symptoms later on. They show up around 3 months later, and they last for a long time. And so, and what happens is someone can experience certain things for a long period. So they can have those disassociative type of interactions, and not just momentarily. I mean, over time, it may change with a given individual that normally they would have normal interactions with. They may be slightly more distant. They may be slightly less engaging. They may have, one of the things that Saldana had was a flat affect. And so what that means is that sometimes there's a situation, like you ever been in a group where you and your friends or you and your colleagues or you and your family, there's, so everybody laughs at a joke. It was really funny. The person said it, everybody's laughing. Maybe there's an individual that's not laughing. They're kind of like stoic in their expression. They're not necessarily responding to it. That could be a way that indicates that they may have some traumatic issues that are coming up. Some folks cannot necessarily respond. It's not a conscious thing. It's just something that happens almost without thinking. And some folks don't have that capacity. And so that gets diagnosed, but it can get treated. The complex trauma is the thing that we see a lot with folks who have experienced something over a long period of time, especially when they started at a young age. When it goes unresolved, guess what happens? You go through life, you show up, you get disappointments in school, you got a bad grade, or you broke up with the love of your life and you're only 15. And then, or you have conflicts with parents, you get through high school, you go to college, you get a job, you have disappointments, it's a struggle to keep the bills paid, but you go through it and you keep going forward. But what happens is whatever has been unresolved right from when you were an infant or when you were a child, those start to build up on top of each other. And complex trauma can have some reactions in different areas of our lives and how we speak to each other and how we engage with one another. And so that can happen. We can see that in our clients. So these are different types of things that we know can get diagnosed, but we see it more in our behavior because you're the peer support. And so it may help us to understand, since we can't necessarily predict who's going to respond, how, we don't always have a file on everybody, we don't always capture the information of everyone's past in the past, everybody's details from their past. Let's just be preventive in how we move forward. Some of the things that happens to the brain, which I wanted to talk about, was this. It's like some folks who have had chronic issues, situations of traumatic situations in their life over a long period of time. Think about maybe someone who has been a victim of domestic or intimate partner violence over many years. What can happen for that individual to survive in their world? What can happen over time is that the brain starts to not function appropriately. So there's a middle part of the brain. The middle part of the brain is really what we call the limbic system. It's the place where the amygdala is. It's where memories are retained, and the associated feelings or sensations of those memories is also stored in that place. And the amygdala has a way of, it's like an alarm. It has a way of helping us understand when we need to be frightened of something. And so anything that's stored in there gets mitigated or processed through the front part of our brain. So the prefrontal cortex is where, we look at different information, we make a decision about it, we kind of decide, how we're going to go forward. We do critical thinking there. And so what the emotions that may come up and a memory that may come up from a particular situations, the brain has the opportunity, and the front part of the brain has the opportunity to be able to process that and make informed decisions and how to respond. Now, it takes a lot, it's a lot faster than the length of time I'm taking to explain this. Now, just imagine that someone has been a victim of intimate partner violence for a long period of time. Maybe they're mitigating those symptoms and their situations by using substances. That brain may be so compromised, the prefrontal cortex, what happens, it tends to shrink. The functions don't work right anymore. And so what tends to override things is that in the middle area where a person may not be able to distinguish between past experiences and present experiences. So when people have flashbacks, so when people react to a situation, but the reaction is really triggering a past memory, that's all because the middle part of the brain is actually responding to it. And maybe that person still may not at that moment have the capacity to be able to process through and understand that they're in the present time. And see, here's what's interesting about this is that, and that's with somebody who's had it over a long period of time. What I wanted to put out. What's interesting, before I go into here, what's interesting about this is these areas that I'm speaking to in the brain are the same areas that are affected by substance use. So those same areas. So if the same areas are affected by substance use, now you got kind of like a double whammy here, because not just the situations that have been impacting them traumatically over a long period of time, but now the brain is also impacted by substance use. Because substance use kind of rewires the brain anyway, and also shrinks the front part of the brain and also retains the memories in the middle part of the brain. So one of the things that can happen for somebody who is, say, a victim of partner violence, or a victim of a shooting incident, or a victim of poverty and discrimination persistently, can be that the middle part of the brain just keeps helps to kind of tie into that flush of dopamine that helps them with the drug seeking behavior, because that may be a way of mitigating those memories, mitigating the associated pain that's associated with those situations. So it's pretty detrimental for some folks. And so it really requires that if we know this, it makes it easier for us to understand why we should be preventive and why are going forward, since we can't predict who responds a certain way to any kind of traumatic experience and who doesn't. It's better to just us to be more trauma informed in how we support. And what I was saying earlier is that most people who go into treatment, a good majority of them do have traumatic experiences that may not show up until the substances are no longer part of their life. So all that helps. Any comments, any questions about that? Kind of deep, isn't it? Yeah. So
that's what I was gonna say, Ms. Diana. It's pretty deep.
Yeah, and sometimes we don't realize that. Even folks who are in the field, that I want you to think about this. The last 3+ years during the pandemic was a traumatic impact for all of our communities. And you folks are doing the work. And the idea here, and this is part of the reason why this is called, this includes self-care, because we're not always aware that the impact that the situation had not just on us, but people we love and in the world, and what we thought was a normal world for us, that leaves an imprint. But if we become aware of what potential responses we might have, then we can better navigate and be able to kind of influence our own symptoms, our own behaviors, our own thoughts. And we can use certain activities to kind of help to process that through. And that's why a lot of folks here understand the idea about recovery capital, right? Yeah. So it's not just for our clients, it's for us too.
Mm-hmm.
Okay, so let me go back to here. So this is another piece of information, culture and trauma. And the thing about culture and trauma, some populations and cultures are more likely than others to experience a traumatic event or a specific type of trauma. Okay, so I'll just read this without you seeing it. Is that hard to understand for anyone?
No, not me.
Okay. Yeah, so the racial and ethnic communities bear the brunt of the biggest disparities, right? We know about racial discrimination. We also know non-binary folks, right? Them too, and even at higher source. As a matter of fact, suicidal rates among LGBTQ youth are higher in that group than it is in the general population. When we think about folks who have social determinants of health, I know I mentioned it a lot, folks who have challenges with being in neighborhoods that their income is somewhat limited, and the struggle of a day-to-day, having lost folks, and still trying to put food on the table, trying to maintain a job. So communities that tend to, say, coming out of the pandemic, for instance, and maybe cope with substances, maybe trying to deal with recovery, maybe have medical issues, just the list can go on and on and on. And it can really, really impact the given individual's capacity to deal. Go ahead, Jairus.
I was also going to say the pandemic, but with several different subgroups. There was the George Floyd murder. So if you're male and if you're a person of color, the idea of quote unquote Karen. So now if you are a woman and your name is Karen, there may be some trauma around how you feel about yourself, how you feel about your name, how you feel about presenting in society, feeling the need to outwardly present as an advocate for others to know, to not feel some shame or something like that. Even possibly with being pregnant during the pandemic and your child not being able to socialize and now having a fear of being away from a child that you've it's just been this small unit for this period of time during the pandemic, so that the basis of the pandemic can mean so many different things depending on which social group you fall into.
Yeah, I think it really, yes, it's such great points. I think it really begs us to be mindful of really listening from the client that we're working with, what their world looks like, according to them. It's not what their world looks like. I got you, Kevin. Not what their world looks like according to what we grab on our assessments. That's one thing. Yeah, we got to capture that data. That's a job. But I mean, what does that person feel and look, feel about their world and how they see it? Because we're trying to meet them where they're at and help them to kind of evolve from where they're at. We have to understand, try to understand as much as possible. That's why you folks are very empathetic at what you do. Kevin, go ahead.
Speaking of COVID, I'm looking at when the people, so many people passed and their loved ones was not able to go to the hospital or to the funerals to see them. That may have been a very, traumatic experience for those people, those families.
That's a good point. The fact that some folks weren't able to have closure the way they understand closure. Yeah, oh man, so many people were not able to do that.
Another thing, I'm sorry.
No, go ahead.
And, I was living around the corner from Bronx, Lebanon, remember? And they had the blocked off, and they had trailers moving out 4 days. Every 4 days they had trailers moving out with dead bodies packed in the back.
Oh yeah.
I used to, that was just, crazy to me, to know that bodies, was just being packed up in the back of the truck like that. That never happened. So.
Yeah, that was pretty horrendous. The last time it did happen, we weren't around. It was more than 100 years ago when they had the Spanish flu. I did a trauma training and I warned everybody to have some pictures. And the pictures look almost exactly the same to what we saw during the pandemic, with the bodies in the trailers, with big places filled with so many people. And it looked the same back then. And it took, by the way, it took them about 4 years for them to come out of it. We're in year 4, in the beginning of year 4. This whole thing started like, we were told to shelter in place in New York in February of 2020. We're in March. So we got the rest of this year. Hopefully we do get out of it, who knows. But yeah, those visuals really didn't help. And you know what also doesn't help? When you are experiencing things like this, and think about your clients as well, and also you for your own health and your own wellness, it's about how often we are glued to that TV and how much the news makes sure that we see all the pictures, all this stuff. If you remember 9/11, if you were around and remember what 9/11, you'll understand what I mean. We did the same thing that we were just kind of glued, we were mesmerized by it, and didn't even realize that essentially what you're doing is you're traumatizing yourself further. It's pretty mind-boggling what the things that have been happening with us. Stacy, go ahead. Good morning.
Morning. I think that really speaks to like culture and community and perception of trauma, because I was living in Alaska when COVID happened, and watching the news, I was seeing everybody in the lower 48 going crazy for toilet paper. And we were in Alaska and we didn't have milk, we didn't have bread. All of our dentist offices, chiropractor, any non-essential medical offices were closed down so that they could maintain equipment and things like that. And I just thought, you know, I was in my head about it, thinking how ridiculous everybody was acting over toilet paper when people in Alaska were also like in fear of starvation. And that was the reason that I relocated back to the Midwest, because it was an extremely horrifying experience and you don't know how long it's going to last. And I was thinking about my family and all of those things. And it was pretty, very, very intense. I know it was for everybody, but Alaska was a totally different experience.
Yeah, I thank you for sharing that. And you've mentioned a couple of things also that that have long-lasting effects for some folks. Like for instance, having had the experience and having survived it and having found a way to kind of be resilient and process it through is one thing, but you still have that vulnerability, you still have the experience, you still have that memory. And it's interesting because I you mentioned the toilet paper, and I remember what I used to see. So I'm Latina, right? And my family's from Puerto Rico. And I remember that in Puerto Rico, when they had the Hurricane Maria hit, I mean, and can't say there seemed to have been a lot of support at the time. And the silly things about toilet paper rolls being thrown around, that island is still trying to come back completely from the hurricane. That was years ago already. And they got hit by the pandemic as well. And so it's really weird and understandable how people react very differently, you know, and how people's mind will focus on certain things because maybe that's their way of dealing at the moment. And even as communities, as groups, we do that as well. Hi, Tracy. Good morning. Nice to see you.
Hi, Diane. How are you? I couldn't get on by my big computer, so I got on by phone. No, I thought about that. And I also thought about Katrina, how the African-American community was hit really severely hard with this pandemic, how certain zip codes could not find food, even upstate New York. I mean, I had colleagues calling me, telling me Walmart ran out of stuff. So it was a thing where we had to exchange. If I found it, we would exchange. I mean, it was that serious. So I'm hearing what's going on, what happened in Alaska. I can only envision their pain, their suffering. But also part of this is also racism. When you think about the trauma, you think about the neighborhoods, you think about people, old people were dying. I eventually retired because I've lost a handful of individuals because they were dying. Even my own dentist said he caught COVID. He was like, look, they was trying to kill me. I told him, get away from me, doctors. I know what you need to do. Just give me the oxygen and it'll surpass. But it's frightening to see what's going on, because even though like you said, we're getting our 3rd year. We still don't know.
You know, and you mentioned about the racism, and one of the things I did want to mention next was about there's so many intersecting layers, and depending on the person, on the community. And when I think about culture and trauma, I also think about traumatic stress or racial trauma, and prominent, prevalent really around with all communities, but not as much as it is with Black and African American community. And so, and this is, and think about it. So everything for, you know, all the disparities for racial and ethnic communities were exacerbated during the pandemic. But guess what was happening during the pandemic? Black people were dying more and more and more, in particular in the hands of police in different situations like that. And so the discrimination is one thing, but the trauma of your community members, and then how it impacts you, and how you have to work with your family, make sure people come back safe, or come back safe from not getting COVID, and hopefully not giving it to the rest of the family, or not dying from COVID, let alone dying at the hands of an officer or criminal justice, or situations like that where somebody else might come out as being racist. Traumatic stress behind racism is also an issue. It's not necessarily in the DSM-5, but I hear that it's going to be included going forward. So traumatic stress, we don't necessarily ask about these questions, but understanding the causatory facts, understanding someone's, hearing someone, giving the space for someone to tell your story, tell their story so you can hear it, where those details comes out, helps you understand what their world looks like, but it helps you understand how that's impacting them. And so that's a very real thing. It's not just that thing, it's a very real aspect of many people's lives. Jairus?
I was just going to mention the social aspect of that, as everyone's talking about how these things have them, made me think about something that's not pandemic related, but Japan's suicide forest for children who are going through their formative years as adolescents. The suicide forest is a very socially acceptable place for when you do not think you're going to do well to go and kill yourself. And this is would culturally be acceptable in that area. And I think we could all agree that here in America, that is not socially accepted. But that in itself would play a large role in how that trauma is received, and how you are allowed to act out on that trauma, and the idea of how socially we all perceive that of, so you're failing in school, you'll never be anything, and you should commit suicide. So those concepts which were socially constructed in that particular area, dealing with school and tests and making it into certain social classes, when you are not from Japan, that can look very different to us than it does to people who grow up in that.
It really speaks to the cultural aspects of things, right? And perceptions. Thank you, Jairus. I didn't realize that Japan was doing that. I got to look into that. Thank you for mentioning it. Cover?
Hi.
Hi.
Okay. We're talking about the pandemic, but it really hasn't died down.
Right.
I mean, the amount of people passing have died, who have passed, the amount of people that has reduced, but people are still passing, and we're still working on trying to deal with this pandemic, this issue. What I have noticed is that the media itself is doing a whole bunch of other things that is causing us to have to deal with a lot of things, and our lawmakers are also doing stuff that's causing us to have to deal with other trauma in terms of dealing with discrimination against women, against people of color, against people, of different sexual orientations. And, there has to be a way for us to just sort of manage this, whether it's, just talking with our family members, or talking with other groups of people, so we can just sort of manage everything that we're dealing with.
Mhm.
That's a comment.
And most especially because it's so individualized. So
Yeah.
yes, I hear what you're saying. And that's the whole point about everything we've been discussing so far. So I wanted to kind of just go into how different environmental factors, but also our internal coping skills or lack of coping skills, or what someone has been conditioned since childhood or over time in how to deal with situations, their perceptions, their values. There's a lot of different things that come together. And that speaks to why you, as a peer advocate, have to really work from somewhere somebody's coming from, understand what their capacities are, so you can best support them in their process. At the same time, gotta support you. The reason why I mentioned pandemic and other things is because those are realities of our existence. To not mention it would be, I think, irresponsible on my part. We gotta deal with our realities and understand that we feel too, and then we come to the table to help support someone else. What we want to do is try to bring as healthy as possible of a person, or as a peer advocate or another professional. We have to bring our best person forward to help support that other individual. So let's talk about trauma-informed care. So trauma-informed care is an adoption of principles and practices that promote a culture of safety, empowerment, and healing. And one of the first things we think about when someone comes into treatment or someone comes into our setting is safety. And so there's a part to realize. The thing about trauma-informed care is that having that concept, moving forward with that consciously and intentionally, means that we realize that that trauma is widespread. It's not always observable. It is more likely to happen with a lot of the communities we're working with, particularly folks who have substance use disorders. And so we understand that it's present most times. We learn to recognize that some behavioral issues may be symptoms of trauma. So let's recognize some of that. We talked about it. So Dana gives you a nice case study that exemplifies some of it: the numbing, the being dissociative, the rationalizing that certain things don't impact. Sometimes the mind does not have the capacity to remember all the full details of something at a particular moment. And so folks may be dealing with a lot more than they are aware of. So we, as peer advocates, want to be able to recognize the signs and symptoms, because that's going to help us understand how we can interact with that individual. So we shouldn't be abrupt in how we engage someone. We might want to be mindful of that. If we have like habits of we move fast, we may want to slow down, because that can re-traumatize someone, may trigger a reaction. So really want to be very present with somebody. So we want to be responsive. So trauma and responsiveness, it means that we understand that we are preventive in how we interact, that the environment is conducive to safety and trust. And so we also exemplify that in how we engage someone. So we want to try to not re-traumatize someone. And sometimes the environment, and I'm talking about the settings, or the rooms that we meet our clients with, or the settings we go out to meet them in, or how we engage them, can re-traumatize someone. And so we want to think about that before. And so some of the guiding principles include that safety is always the first one that we talk about, and also being trustworthy and transparent. It really has a lot to do. It also intersects with the safety piece, because there are times where decisions have to be made, and you want to support the individual, but you also kind of want to collaborate with them. So you want to be able to be a source that they can rely on, that they can depend on, in terms of you being forthcoming, you being straight up and honest, and not giving surprises later. And so that peer support is really important. The whole thing is about empowering folks. And so you want to collaborate, you want to partner with them, you want the mutuality aspect really has a lot to do with the fact that you are there to help support them, and they're there for a particular need. And so decision-making can be done together. You help to give the information that helps them make an informed decision for themselves. You're also the person that helps them navigate the community, helps to do that without using substances. Because this is for folks who are working with abstinence-based recovery programs. Many settings are, doesn't mean that everybody is. I'm not trying to say one or the other, but you're working with what they want to do. And so their voice is important, their autonomy, and supporting them, even with things that you may not necessarily personally agree with, but if it's for them, you want to be able to give, you want to be able to be right there with them. And so also the cultural, historical, and gender issues that may come up, you want to be able to recognize that and respect it. And when I say respect, I don't mean to not be rude. Respect means to integrate those aspects of who that person is into every decision making, every resource I'm trying to suggest for them, every way I speak to them. That's what I mean by respect. And so it really speaks to some of the recovery goals. So, we want to inspire the hope. We talked about safety, so calmness on our part is really important. We do want to support self-efficacy on their part, and that will happen in time. We want to be able to use some of these principles, like focusing on their strengths, help them connect back to the community and learn what the recovery capital is, so they can continue in their own wellness process. So doing all that really speaks to certain things. So let's think about this, like just think about the trauma lens. If the trauma lens is off, sometimes we look at people and we get this idea that comes up in our head, like we think, oh yeah, that person's kind of lazy. It may not be lazy. Just challenge yourself to look at it differently. Maybe there's something that it looks like it's lazy, but there's something maybe happening here that makes it look that way. Maybe that person's overwhelmed. Maybe that person's like really, really tired, and we don't know that they're doing certain things. Maybe they're having trouble sleeping, which is really understandable, especially for people coming into the recovery process in the first few months. So maybe they lack the skills to make decisions about what to do first, how to organize, and they're just comfortable right now. So there may be a lot of other reasons. The whole idea is to think about potentially what our first notion might be of what we see, and question it. That's what I'm going to say. So instead of thinking that somebody's being manipulative, I always encourage folks to think of it, why would it be manipulative if they're trying to get their needs met? They're just doing it the best way they know how. So that takes a couple of extra seconds and a bit of an effort to kind of think of things differently. It's like giving the benefit of the doubt. You never really know. You're not in that person's head, so we don't want to make these assumptions. We're not supposed to be doing that in our work anyway. So the person's getting their needs met the best way they know how until they learn different. That's what we're there for. That's what the program services are for. When someone is thought to be resistant, maybe some of their trauma is really playing a part in why they're not trusting folks. Maybe they're very timid. Maybe there's a lot of the past trauma impacts still happening in their lives. So maybe they don't want to be hurt by someone else. Maybe they don't want to trust. Maybe they're at a point where they don't feel like they deserve it because of the traumatic experiences. That may be out of our purview, because it's not really our job to kind of unpack all that. But just when we see someone is resistant, there's always a reason. Guess what? We can have a conversation. We can ask, right? When we think that somebody's unmotivated, they might just be maybe depressed, or maybe they are frozen. When we think someone's being disrespectful, guess what? Maybe someone's reacting. Maybe maybe has absolutely nothing to do with you, although you're the one that they may be lashing out of. Attention seeking, maybe somebody's feeling disconnected. So it's just a way of looking at things a little differently. And so when we're speaking with someone, instead of telling people what you're going to do before you do it, and it's important to tell them what you're going to do before you do it, because I remember I spoke about the transparency. But also think about, instead of asking, what's your problem? Why are you here? Can you tell me what happened? Open-ended questions are really great, and make this time and space for someone, if someone's feeling comfortable and is trusting you in that moment. So make the time and space for them to tell their story. So important. Strong responses are adaptations, not manipulations. So what about you? What about the peer advocate? What about the peer specialist? How do we talk about that? So many times, folks got into your profession. Most times you got into it because you like to help people, right? What are some other reasons why you got into the field? If you're okay with sharing it, you don't have to. Daryl?
Opportunity, I guess it was opportunistic.
No, that's
Yeah,
cool.
I was actually, this was years ago, I was actually in a men's shelter
Mhm.
and looking to get a job, and there was a flyer on the wall. This is way back. Free training. It was Bronx Seven. Somebody mentioned Bronx Seven Hospital. I was in Franklin Men's Shelter, which is like 2 blocks up, if you know the area. And there's a woman's shelter now. Anyway, it said free training to become a peer educator, 8 weeks. I said, okay, I signed up. So that's initially got me into the field. At that time, the peer education around HIV and AIDS. Years later, it segued into substance use. And
so you was in position, huh?
Yeah.
Very good.
So this is
you.
just opportunity.
Okay. Thank you, Daryl. Malika?
As a CASAC, you're very structured in how you have to provide services. As a peer, you are more able to help the client I don't know, I don't want to say self-help, but kind of direct their own treatment. In a treatment environment, like a residential or an outpatient, there is a clear set of criteria that you have to use for clients, or we still call them clients. In a peer environment, you're more able to use harm reduction. You're more able to help the person kind of navigate recovery on their own terms, as opposed to, and it's not punitive. A lot of times in treatment facilities, there's a lot of punitive things. If you get a dirty tox, or if you don't show up to group, and where as a peer, I'm more able to kind of figure out why the client is not doing what they're doing, and kind of helping them navigate on what they want to do and how to get them to the point that they want to do it. So it's not abstinence only.
Right.
As a lot of times it is where, as a CASAC in a treatment facility.
Right. Thank you, Malika. Alex?
Yeah, so I mean, just to be very basic about it, and hopefully this doesn't trigger anybody either, but I've seen too many of my friends die. You know, that's the long and short of it, is I just don't want to lose another person, whether I know them or they're my friend or not, or in general, is nobody should have to end up losing their life over something that can be treated, and that we have effective methods to help people with. It's the same thing, with if somebody was to die from diabetes, it's like, if there's treatments there's people that know how to help. They know, there's doctors, there's things that can handle those things. But addiction's not treated the same way, in that when you have an addiction problem, you can't just go to the hospital and say, this is what I'm dealing with, and they treat you like a normal human being, and they actually address your symptoms and get you on medication and all that stuff. With addiction, it's not the same way. So the reason why I'm in the field is because I genuinely care about saving the lives of the people that are struggling with the same things that I did.
Thank you, Alex. Thank you so much for sharing that. Joshua?
Yeah, I gotta just a little bit contradict on what Malika said just a little bit. Actually, I am a CASAC, and we use very person-centered approaches, harm reduction approaches, to the point where, OASIS even tells us, we can't be punitive. I work over at an OTP clinic, and we used to be able to set contracts and all that on individuals, but now, even as long as they're getting their methadone, that's okay, but I got into the field because of personal experiences, and just seeing family growing up, going through substance abuse, and wanting to help individuals out, deal with that, get to that method line. And I actually believe that harm reduction helps out a lot, and just like we said before, meeting those individuals where they're at, I think is very essential. So, yeah.
And thank you for that. One of the things that has been happening in the field of treatment is that the recovery-oriented perspective has been informing and helping to change that. Not everybody's doing it just yet, not everybody, but the recovery-oriented perspective, the oriented systems of care are really are finding a way into the traditional treatment modalities, you know, as I had been. It's a really big difference from having a treatment program that has a lot of different services, right? And a person comes in and you do all the assessments and capture all the information. You do a treatment plan and then put them into that structured environment. And recovery-oriented systems of care, this is how I see it, is really a way of looking at all the different services and making them fit to the person, which is a little different. And how it should be, and that's meeting them where they're at. And I just kind of plug them and oh, Seeking Safety is here, and you know, and the social program is there. It's different, just really tailoring it. And because sometimes we kind of get lost along the way, and I think that's what happened with some of the systems. And recovery-oriented systems of care has been really helping to inform that. And the peer advocate movement and recovery coaches have really helped in that as well. And so thank you all for sharing that. You know, the heart of hearts is really part of this. You folks have already experienced certain things and you want to make a difference in other people's life. That if it can help save even one life, your whole life has been more than worthwhile. You know, and yet you're in the people working field. And one of the things that's so important is that you got to take care of yourself. It is your ethical responsibility to take care of yourself. Look at that. When you're in your environment, you have to focus on that individual. But if you're feeling ungrounded, then you got to take care of you because you're going to bring that person to that. So this is really important. So peer support is a way for people from diverse backgrounds who share their lived experiences in common to come together to build relationships where they share those strengths, where they share and support each other's healing and growth. And thank goodness that the communities have you folks now. When I was doing treatment, we didn't have the peer professional. That was like unheard of, and it was more punitive in my time when I'm talking about, you know, 15, 16, 17 years ago, and when I was working in the treatment setting, and it was a very different approach. And I'm grateful for research. I'm grateful for the recovery-oriented systems of care philosophies. I'm grateful for everything that has helped us evolve to go in a direction that will help support the communities much better. And so the peer support, you folks tend to use your lived experiences to help other people. So part of it is, you know, the emotional aspect of it is, you know, you support mutual emotional support through recovery activities, how you help them connect with others in recovery, or build their recovery capital. You know, you do provide other information. You also have not just, you have training and you have experiences that has to do with how a person's health can change once they're coming, how they seem to change when they first come into treatment. A lot of folks may not have necessarily put in a lot of effort in their wellness and their health when they were still using substances. And so when they come into treatment, there's no, if there are no substances in their body, if that's the process they're using, you know, the body starts to react very differently. You have an opportunity to help provide information that can help them, you know, start to learn how to take care of themselves, how to deal with their specific issues. You help folks kind of navigate through life in general, pick up different life skills and community resources. And all of that is part of what you do. But a huge part of what you do is how you bring your heart to the table. So the empathy is a complex, cognitive, and effective process that allows human beings to experience concern for others. Part of what you do and what brings you in the profession and what you bring to every client you work with tends to be, and this is for peers, this is for CASAC, because I know you're not here because you want to get rich, because none of the positions you have would kind of get you there. You're here, you're doing what you're doing because you like to work with folks. So that empathy that you bring is so huge because people connect with that. People can feel when someone really cares about them. People can understand when someone is trying to listen to what they have to say. So when you're able to understand their emotions, and it helps you help them and helps create that safe space for them, and then it forms that they call it therapeutic alliance, but that connection that you have with any given individual that looks very specific to that and to what you have with that individual is so helpful to how you can help support them and how they can be receptive to some of the experiences that you have and how they can make informed decisions on how they can take care of their lives. And so what happens with that though is that when we help others, it's almost like risking ourselves. So peers may be exposed to trauma by events they observe. The stories you hear sometimes have an impact on you too. And so, constant exposure to this can certainly have an effect on you. So it can trigger emotions, maybe some related to your own past experiences of trauma and loss. And so trauma is psychologically distressing. We do know that. But the exposure response, it's what we want to recognize in ourselves. So within us, there's the result of exposure and the suffering of others, living beings in the planet, can have external trauma responses within us. So it can lead us to professional vulnerabilities, I'm going to say. So compassion fatigue, vicarious trauma, or burnout. Let me see what you folks are saying here. Yes, Tanya. Yeah, it takes time to build, empathy takes time and trust and feeling safety to be firmly established. And for some folks, it might take, and for people who have traumatic experience or trauma in their life, whether they're aware of it or not, it might take a little longer with some people. And you may have noticed that. You may have noticed that connected to someone who is in a treatment environment, might just by doing that is enough reason for someone to kind of just be checking everybody out, see who's for real, how things work before they can start to actually, be open to you or trust you. But right now we're talking about, let's talk about us. I'll talk about you. Let me just say you, because you're doing the direct services. If you are, there's such a thing as an empathetic strain where you as the peer or the CASAC or the professional have been exposed to so many different stories you've heard, so many different challenges that you help different people on, and your emotions kind of get caught up, and it's part of what drives your efforts to help someone. That can have an impact on you where you may start maybe with some folks, you may have some signs that you might want to look for. If you start to feel like you can't get anywhere with different people, you feel hopeless, or you start to get hypervigilant, or you have your own kind of sense of dread, or maybe your irritation kind of grows, or you're more angry, or maybe you minimize situations, or maybe you're not as patient anymore. These are different signs that show that sometimes we are experiencing our own issues, often related to hearing the stories and helping folks. And so vicarious traumatization can be thought of as when a peer helper is emotionally engaged and working with people who experience trauma, but it can shift or disrupt your own sense in your own life, in your own perspective, And so it could really shift your sense of hope, and you may not necessarily realize it. It happens in a very insidious way. And compassion fatigue is a little different. It's used very interchangeably with vicarious trauma. Sometimes you hear secondary traumatization. And this is really interesting how this is worded. I want you to think about this. It's the emotional residue or strain of exposure to working with those suffering from the consequences of traumatic events. If some of your lived experience included having had your own traumas in situations in the past, and you have gotten, maybe you needed help, maybe you've been able to use your recovery capital or your 12-step fellowship and use those processes to help kind of resolve and get better with those things. What I mentioned earlier is that it tends to leave a footprint. And just the fact that that did happen, the memory can be re-triggered to some extent. And so you may see it coming up. And so compassion fatigue can speak to that residual imprint, and the overexposure to all these other folks' situations can actually build it can build your sense of hope. You can really impact on that. It can start to make you feel pretty strained. Sometimes just kind of triggering, traumatic events in your memory. Maybe not necessarily impacting your behavior, maybe impacting some of the words you say, or or what you might not do in certain times. Burnout is a little different. Burnout means there's a lot that you're dealing with at the job, at home, in general. That's burnout. That's different than what we talk about when it comes to compassion fatigue. And so it's stress, but it is stress-related symptoms, when it comes to compassion fatigue. So I want to ask you folks something. Let me see. Kevin, can you read this? I know you spoke earlier. So Kevin, can you read this out loud for everybody?
What if sometimes someone gets too close to you at the grocery store, and then all of a sudden you feel irritable? You struggle to get through the day, feeling the need to be cautious with every move. Calming yourself and trying to push through the day becomes your priority.
That sounds like the corona epidemic.
What was that?
I said that sounds like the COVID epidemic in general.
Well, okay, so all right. So the COVID happened, we're in today. What if this happens? Let's bring it to the present moment where, okay, so you feel like this is, let's see if you sense, if you can see yourself in these shoes. What if this is you, that does speak to a certain amount of awareness. For someone to actually be able to understand that they're just kind of struggling, they can't wait till the day goes through. There are times where it's like, what, 10 o'clock, 11 o'clock, and it's like, oh, Jesus, it's not 3 o'clock yet, it's on 4 o'clock, I want to go home. Like, it's not necessarily our normal way of being on a daily basis, but this is how we feel. Maybe are we feeling stressed? Do we have that awareness to be able to do that? Or are we so caught up in our environment and our responsibilities and our routines for every day that we may not necessarily pick up on that? Jairus.
Yeah, I mean, some of it I do believe plays back into, as we spoke before about ACEs and childhood trauma and kind of how things are formed for you. Me personally, I'm 6'7". I am a Black guy. There are many things that I potentially think about every day in moving about, where I have to reassure myself that I'm not doing anything wrong and there's nothing wrong with my presence. Standing too closely on the train can trigger people just by my size. Sometimes I have to remind myself I haven't done anything. And even if you're with a client, I had actually wanted to say this earlier, I thought about it later. I've had a client who was triggered by my appearance and how statuesque I am, how tall I am. That in itself was a trigger. It had nothing to do with how I was assisting the person or what I was assisting them with. It was my physical appearance was a barrier for that person. Having the understanding within myself to not put those feelings that they felt onto me or make somehow a correlation that I haven't done my job. I think another large part is also realizing that I am just a piece of recovery capital for that individual. And there are many other pieces. So not making myself the end all be all to help or put that pressure on myself, making sure that I help distribute that weight and make sure that they have other resources.
Good, thank you so much. Tracy?
I've learned that when I have those feelings, take a mental health day. Sometimes you have to leave work, sometimes a half a day and say, I gotta go, because you get triggered. I know I do. When I get triggered with certain things, I know it's time to go, because it's not fair to the client to have to feel that energy I'm having. And I've learned to gracefully bow out.
I think that speaks a lot to your self-awareness, and which is what I'm trying to stress here. Thank you. Kevin.
Yes, I believe that self-care is it's a critical component in this field because, like you said, every day dealing with patients, clients that go through some trauma, addiction, whatever it may be, you can easily take on that. And I don't, try not to take it personal. If a client just spaz out because, they're going through something. So when I'm not working, I try to unwind. I don't care if it's going to get a haircut, go to a movie, just relax. Because I know when I get to work, it could be heavy.
So that still speaks to your own sense of awareness, and it's glad that when you are aware, you know that you have to do something to kind of maybe balance out a little bit, although that might be not necessarily the fairest way to put it. Balance is a very hard thing to achieve and maintain unless you're doing it on a daily basis. Hi, Robert.
Hello. In this scenario, it would be normal for me to be upset if someone got too close to me because I don't like people being too close to me.
Mm-hmm.
If I let it wreck my whole day, then I would have to look at why that was happening and realize that I might be having a problem.
Yeah, that's true. So this is so the thing is when these things come up, it's like kind of like your red flags. It's like, okay, what's going on with me that I'm feeling this way? Again, let's speak to awareness, but sometimes what happens, we have there's certain feelings or notions that trigger in the moment. It could be because someone is in your space. It could be, or it could be something that's not, you're not used, what I'm looking for is for us, when are we aware when we're doing something that is not common to who we are? But if it's not normal and we're feeling agitated, and so let's not dismiss that. Let's look at that. That's a reason for us to take a step back and say, let me see what's going on here. And if I can't do that, if I'm not sure, where else can I go for support? Where would I go? If I'm a peer advocate, where would I go?
Personal support network.
Okay, yes, personal support network for sure. You can go to your peers too. For that.
You have therapy. This is Tracy. I go to therapy. Therapy is wonderful.
Okay. All right. Therapy, that's another resource.
Your supervisor.
Supervisor, you do have supervisors who hopefully you have a nice relationship with, so you can run things by. Any other questions? Any other suggestions?
Employee assistance program.
Okay, EAP. Actually, I stress that, especially if you folks have experienced a loss in your area. Yeah. What else, Sylvia?
Some of us are spiritual. We can seek out a spiritual resource. You know what I'm saying?
That's right.
Yeah.
A spiritual resource. So it's really about taking a step back and say, okay, let me look at what's going on. I'm feeling like this and finding out where that's coming from. Because if you ignore it, what happens is it'll come out somewhere. It'll come out in your interactions. It'll come out in what you do or don't do. And guess who's the one who's going to be the recipient of what you do and don't do when you go back to work? And that'll be the client. And that's what we're trying to avoid here. So asking for help may not be the easiest thing for some of us, but it would be the critical thing for some of us. And so, and I will send this along for you, but I suggest, sometimes when we're not sure, there is a 5-question scale that is out there just for people to just be able to look at themselves and just look at what, if something is stressing them out, and just to check in with yourself. And so this is something you do for yourself. You don't do for your supervisor, for your peers, for anybody. This is for you to be, if you think something is going on, just check in on yourself every once in a while. Any professional, no matter what capacity you're serving, if you're working in the field, helping other people, you need to check in on yourself every once in a while. Psychologists have to go to another psychologist to debrief. Psychiatrists have to do that. The issue here, the concern or the question is, do we actually do that? So at least you got some tools, and also we'll send this along with the slides. We got some tools that we can look at to see how we are scoring in terms of maybe compassion fatigue, or maybe we have some of this burnout, you know, and that's, and if that can be a way to affirm or confirm what you may be feeling, then maybe start to look at, well, maybe it's time that I need some me time, you know, some conscious, intentional me time. And so here's another situation I am going to ask you to read. Let me see. Anita, could you read this, please?
Yes. During an encounter, you were very impatient with the last client you met with, interrupting them while they discussed the situation with you. After a few minutes, you realize you are frustrated and dictating to them on what they should do instead of asking what they could do.
Thank you, Anita. Now, this is you're there with the client. So what do you do, or what can you do next? What do you think? You become aware that you're doing this. What's the next step possibly?
Do you want me to answer that?
You can answer that, and anybody and everyone else can chime in as well.
I'm glad you asked, because this has happened to me. I had to ask for a moment, and I had to explain that I needed, just a moment, that I was kind of going through something, and I excused myself for a moment. And then I had to seek my supervisor after during supervision for that. So.
Okay, thank you. So there are things, asking for help is really the ideal here, but here's the thing. There's also other things you could do. The idea here is remembering like where you're at and how is that affecting the other person. Can you be there for the other person? There's nothing wrong with saying, let me take a step back, or I need a few minutes, or saying, maybe that person is talking about certain things that are really triggering your stuff, and maybe you're still resolving your own, and maybe you're not the best person to match up with that person. It's okay to make room for that person to get help from someone else while you're working on your own stuff. It's okay to do that. The wonderful thing is, like, you can build that awareness to understand, okay, do I go this way? Is it impacting them? Am I healthy enough to be here to help them? And so thinking about that. So the supervision, using it as a teaching example, yeah, you can apologize and excuse yourself or give yourself a few minutes, and certainly don't let, it's really not letting them think that it's about them, that there's something wrong with them, nothing wrong with anybody. But if something's triggering you, then you need to look at it. Those red flags should not be ignored. And so over here, I asked, Denise mostly wants to talk about the details of what happened to her. She has a tough time talking about her life in the now. So something you could say is something like, so I'm so sorry for the things you experienced in the past. I've experienced some of these tough things too, including abuse. While I won't share the details, I'm happy to share some of what happened to help me get through it. So here, this not only helps them, but it helps you as well. So this is a potential thing you can do, and this comes from the recovery literature. And so this is the only reason why I put it up there, is because there are certain things you can do in the moment to still help the other person and yourself at the same time. So so let's think about some of these things. The idea of you taking care of yourself, you're in the people field. This is really important for you to build your own resiliency. So there's certain things that should not take second place or back door. And I know I should practice more of what I preach. I love being by a computer way more than I like to, but I know that if we don't get away from the job and forget there's a life out there, it will start to show in our work performance. It will show and reflect on the client we're working with. So reach out to your family and friends, get involved in the community, do different things that you like to do. If you have a day that you can sleep later, take it. Tracy said it, it's like mental health day for yourself. You have it, you actually can take those. Make sure make sure that you consider that your Saturdays and Sundays. I know we all, Saturdays and Sundays, many of us are trying to catch up to the chores we couldn't do during the week because we're working. What's wrong with taking a day just for ourselves? Participate in trainings that help you strengthen your own resilience. One of the things I stress a lot about is mindfulness. Mindfulness meditation. I'm a big believer in meditation. That's because I practice it myself. But just mindfulness, the concept of mindfulness and being in the moment, this is something that can help your clients as well as yourself. And it's like sometimes when folks go back and kind of get stuck into only talking about, what happened to them, sometimes that actually can put someone in an uncomfortable space. It's also about being able to be in the moment. What are you doing? What can you do for yourself right now in this moment? And so it helps you regulate your emotions, helps you regulate your physical reactions, and just builds your self-awareness. And so it's a nice thing to do. So if meditation itself can do something, can help. A lot of folks that I've known before I started meditating, what I've learned from a lot of other practitioners is that when you meditate in, like say early in the morning before your mind has a chance to be filled with 100 different things that you have to do for the rest of the day, you do have an opportunity to sit still. You do have an opportunity to go inside within and be able to kind of just not think of anything in a way that will help you once you get out of meditation, whether it's 5, 10, 15, 20 minutes, once you go into your day, it helps you not react to situations. It helps you to have informed responses. You're a little calmer. You're not as agitated. You're not as high stress. And so I remember some folks telling me that they had moved from they were too busy to meditate to they can't, they were so busy they needed to meditate because it helped them throughout their day. And so some self-care essentials really speak to that awareness piece. We love working with people and that's wonderful, but we can easily get lost in that process. And so don't lose yourself in that process. If you don't realize or are aware of who you are, what your belief systems are about, how you're feeling at the moment, then you are not necessarily going to be able to see that person for who they are or bring the best person to help them. So your self-awareness is what helps you be as proficient at what you do as you are. Supervision, we already mentioned, super important. You folks have that. Other peer support, love peer support. Other folks who understand exactly what I'm going through, when I'm going through it, a source that I can tap into or somebody I can call in a minute. That is fantastic if you have it. Your own self-care. Self-care just means to take care of you. The thing, sometimes self-love has to do with doing things we need to do, not necessarily the things we want to do. We want to be successful at school. We want to get those degrees. We want to be successful at work. You know what? To be successful in anything, to be helpful in the community, you have to take care of you. So do healthy things. Get into the habit of doing healthy things every day. Maybe certain things, have your time in the morning. Before you start your day, it's going to be very busy. Give yourself that time to just enjoy not rushing and just being in your own space. Trauma-informed principles are not just for the community that you work with, but they're also for yourself. Work-life balance is always encouraged. Like as much work and effort that you put into the career that you love so much, it's also that much more important, that much important to put that same type of effort and energy into you and things you could do, other things to help balance out. All the other things that you do also help inform what you do at work. So set those emotional boundaries. And these are some resources here. Any comments, any questions?
Could you go back to the resources?
Sure. You're going to get these slides, by the way.
Oh, great. All right.
No. All of you are going to get these slides. And you're going to have these resources, and you also have some resources at the bottom of some of the slides, and you're going to get that 5-question scale. I should have had it here to have it, to put in a chat box. I apologize. But so the whole idea is to understand that there are reasons why people respond the way they do in their world when they have trauma, especially folks who have substance use disorders. There's a lot of reasons, and there's a lot of vulnerabilities in our current day that impacts everybody, them, us, you name it. What you can do about it is understand how it works And if you help in the self-care piece, if you take care of yourself, your body's less likely to be reactive to situations, and you're more likely to make informed decisions in your mind. And so all the same principles that I talk about to work with our clients is the same ones that we can apply for ourselves. Take care of you because they need you. All right, then. So here's what I'm going to do. I appreciate everybody being here today. Give yourselves permission to have a super awesome weekend. I don't care if it rains or not. I have to love the rain. Just give yourself permission to enjoy yourselves this weekend. All right. And I really appreciate y'all being here. Hope to see you all again.
Thank you, Miss Diana. It was a great training.
Welcome.